I think the key with all of these talks is, again, like I said before, this is a lot of information. But the really important thing to remember is that screening guidelines are just that, they're guidelines. And all of this information is basically to help you have more informed decision making with your physician. Because even though these are guidelines that are generalizable, they might not necessarily apply to you because everyone's risk is individual. And so, you know, for this gentleman before who was saying, do I get the colonoscopy, do I not? I think the next question is always to say why or why not. You know, in what context do I really need this screening mechanism, or in what context do I really not need it? Why don't I? And having that understanding will make that decision better and more valuable for you too, because you want value to come from whatever tests you undergo in the end. If it's not going to be beneficial, why should you have that test? If there are potentially more harms from having that test, why should I do that? You know, so it's really important to ask that second question of not just do I do it, but why do I need it, so that you can make that decision with your doctor and it's not you in a silo or the doctor making the decision and putting that on you. So for breast cancer, I'm not going to talk about individuals who are high risk for breast cancer because, again, that particular group of patients or potential patients is extremely nuanced and it's very individual based. But I do want to make sure that I mention the generalizable guidelines for breast cancer because this has been very controversial over the last few years. So there's various mechanisms for which we talk about screening for breast cancer. One is the clinical breast exam, one is the self-breast exam, the digital mammogram, an ultrasound, an MRI, which one works, which one doesn't, which one do you need to participate in. And the main thing that I'm going to focus on is the digital mammogram, because that is the one that has been proven to, when we talk about screening, but the idea is that we want to catch cancer at an earlier stage when it's easier to treat versus catching cancer later where it's much more difficult to treat. I love this pictogram. This is from the Worldwide Breast Cancer Organization, and this very nicely summarizes in a very picture-based way, what does this mean, what do I need to do? So the idea is if you don't have any symptoms, the next step would be, do I need to go to the doctor to then get a mammogram? If you're over the age of 50, you should be getting a mammogram every year. The controversy lies in this group of women who are between the ages of 40 to 50. If you have a mammogram and they're not sure whether they saw something abnormal or not, you might need additional imaging, and that's when the ultrasound and potentially an MRI and additional mammograms becomes very important. And based on those additional findings or additional images, they may or may not see more. And so you might be put into the category of getting imaging at a later time, or you might be put into the category of getting a biopsy right away. So a lot of times patients come to see us and they said, oh, you know, they saw something on the mammogram, now I'm really worried, but then why aren't they doing a biopsy? Why are they telling me to come back in 3 to 6 months to get another image? That's okay. That's not the wrong thing to do. And that just means that they saw something, but they didn't think it was really cancer, but it wasn't something totally normal where they want to ignore it either. So that's fine. But if they see something abnormal and they tell you we see something abnormal, it's definitely a discussion and asking them whether you need that biopsy or not. So that's a good question to ask. What they might, like I said, they might do be after that when they see something abnormal is either more mammograms, an ultrasound, or the MRI. The MRI is saved for particular cases, so if you don't get an MRI, it's completely fine too. And the problem with MRI is that it's extremely sensitive, but it's not very specific, meaning it catches a lot of stuff that's not cancer, and so that's why it's not used on a regular basis.
Is that true for different things, not just for breast, any MRI?
No, that's definitely not. I'm just only talking about breast MRI. MRI is very good in a lot of other contexts, especially musculoskeletal disease and sometimes in liver, so absolutely not generalizable at all. I'm only talking about breast. So, like I said, women, most groups, so there's about 3 or 4 different groups that have different screening guidelines for breast cancer, but most will agree that after the age of 50, you should have a yearly mammogram. Again, not talking about patients who might have had a previous history, who have a family history, who have a genetic disorder, who fall into different category of normal versus high risk. I'm only talking about the normal risk individuals. Between the ages of 40 to 50, that's a discussion with your primary care doctor about whether you should be getting yearly mammograms, every other year mammograms, whether you should just start at 45. Those are all the different nuances, and that's where it gets really difficult to understand whether or not you need it. But generally it's 50 every year. And there hasn't been much benefit, it hasn't been shown to be beneficial to go beyond the age of 75 to 80 with yearly mammograms for the exact same reason Joe just mentioned with the colon cancer, the likelihood that you'll die from a different type of disease or a different reason, it will not necessarily be from breast cancer. So continuing with the screening might actually be more harmful, meaning you might need unnecessary biopsies, is a real thing. So the clinical breast exam. So this is also controversial. Should you actually have your doctor examine your breasts? And one group says yes, and one group says no. And the reason people say no is because they're always looking for that. Does it translate to me being less likely to die from this disease? Okay, that's the end point we're kind of looking for. And so the answer is no, but if you're not doing self-breast exams yourself, that clinical breast exam that you have yearly might actually be beneficial. So we still recommend, many doctors still recommend, OBGYN, surgeons still recommend getting a clinical breast exam once yearly. I mean, you have to go to your doctor once a year anyway, so that would be a good thing to have beyond just the mammography. So when you're doing a breast exam, what should you feel for? Things can feel different. Lumps and bumps feel different. And I love this pictogram, which shows the different types of things that you might actually feel in your breast. If something feels hard, almost like the lemon seed, then that's a little worrisome and you should probably go to see your doctor. But if you feel something that's softer, like a bean or a pea, and it feels really round and you can move it around, it probably isn't breast cancer. But if you are really worried, you should go see your doctor. But it's the hard thing that feels like a little seed, that's what we worry about. So for cervical cancer, again, controversial, and the guidelines have changed quite a bit as well. What we recommend is that women get a pap smear about every 3 years from the ages of 21 to 65, okay? There's some groups of women who could get it every 5 years, and women under the age of 21, which is one of the areas that has changed, should not actually get screened on a regular basis, which is different. And then there's a vaccination for HPV, which has been linked to a higher risk of developing cervical cancer. Those women need to continue on a regular screening schedule, like every 3 years, after discussion with their doctor.
What about after age 65? They don't?
No, not recommended. So the one thing that we know is that cervical cancer can be linked to the HPV. And therefore, it's recommended that women between the ages of 13 to 26 who haven't finished their other vaccines should get an HPV vaccine. And this is also for men as well, that between the ages of 13 to 21 should consider getting this HPV immunization to decrease their risk of getting there's other anal cancers and so forth. So, what should you walk away from today? Because again, we gave you a lot of information. What are those things that you can do that are modifiable? Eating healthy, exercising regularly. If you're a smoker, quit smoking now. Those are the things that we've definitely seen linked to an increased risk of cancer. getting a checkup once a year is very important, and developing a schedule for your cancer screening with your primary care doctor who you do see once a year is extremely important, because like I said, there's so many nuances in these screening modalities. Is it going to have an impact on the length of your life, and will it be effective for you as an individual? Is an extremely important discussion to have with your doctor. And so that's going to be different for everyone. And so if you have that schedule that you've created with your doctor, it's easier to think about whether or not you should follow that or not. And then it is based on you as the individual. Okay? Do you guys have any questions about women's cancers? I can't answer the colon or the prostate. Yes?
Okay, I don't want to put you on the spot, but.
Well, if it's excuse me, sorry. If it's about you personally, I can
No,
answer it.
no.
Okay.
In terms of screening for ovarian cancer.
Uh-huh.
I know there have been problems with the different screening tools. When I went to the website for the NYU Langone, trying to find it,
Mhm.
I've been told that there were past presentations that were online. I couldn't find it, but looked that there was something about that maybe the risk for ovarian is not necessarily linked directly with the risk for breast cancer. The bottom line is, are there any new screening tools that are down? It's still.
No, I mean, notice that I did not speak about endometrial cancer, and I did not speak about ovarian cancer, because again, the whole idea behind screening is to catch things at an earlier stage, or that are effective. That's the whole point. That's why there's been so much of a change in these screening guidelines, because we were doing a lot of these things, but then people are starting to look back and say, wait, are these really effective? Are we really saving lives? And so the problem is, for ovarian cancer, there really hasn't been a methodology that's been effective in decreasing the death rate from ovarian cancer. Now, the subset of the populations that I did not talk about are women who are in increased risk of cancer, women's cancers, and so if you have a genetic disorder in the family, or someone had ovarian cancer in the family, then that's something you should mention to your primary care doctor, because then you may come up with a different mechanism or a different visit profile for yourself. Yes, sir?
I forgot to treat it with the health newsletters, and pretty many were saying that the mammograms as they are now, as much as 30% have false negatives or false positives, and you do mention something called Cervical, heat-seeking device, and I was wondering whether you mentioned that, because cancer cells produce heat, and it should be more accurate than the ordinary mammogram. Of course, the MRI is also very accurate, but it's expensive, and not all insurance companies would cover it. So what do you have to say about sonograms?
Yeah, exactly. That's exactly why that is not part of my presentation, because there are different types of tests that are being checked and reviewed to decide whether they are effective and actually catching cancer, and they're good screening modalities. And as of now, that is not an accepted screening tool. But people are looking at it. Yeah.
But you told me about that 30 years ago.
Can you talk a little bit about the incidence of breast cancer and screening need for men? Because I've heard that there is a small percentage of men that get breast cancer.
Right, so I did not focus on the population that's at risk, has a higher risk than every individual for breast cancer. But there is a subset of men who are at risk for breast cancer because it's hereditary, because it runs in their family. And so again, that's a discussion with your primary care doctor to decide if you fall into that category, whether you need some additional tests to determine whether you fall into that category, and then if you need additional screening for that.
But do they get like protrusions on the chest? Because normally.
Well, if cancer is symptomatic, especially with breast cancer, often the signs and symptoms are feeling something abnormal, like I showed with that picture, feeling like the lemon seed. Sometimes people have bloody nipple discharge. Sometimes there's
I'm sorry, what kind of
bloody nipple discharge.
nipple discharge?
Sometimes individuals have skin changes that almost look like an infection, or that your skin just looks thicker. Those are all things that are not normal, but just noticing a change, any change should propel you to inquire, okay, is this something that's new and is it being sustained? Should I go see my doctor? So just being aware, self-aware of what you're used to with your own body is the reason to propel you to see your doctor.
Excuse me, doctor, radiation to the chest.
Let me just take
also?
her question, because she had her hand up. Sure.
In relating to men's breast cancer,
Uh-huh.
when they look for BRCA gene.
Exactly, yeah, and that's a hereditary.
It would be there, the same as it would be in a woman, to see if they're.
Yes, so there are women who are in the high risk category, and one of those groups of women are people who have a genetic disorder, meaning they actually have a gene that says that their risk of developing cancer in the future, which is not just the BRCA gene, but the BRCA gene is the most well known, and you actually have to get a test for that. And that's something you can discern with your primary care doctor, because they will talk to you about what your familial history is with cancer.
Can they do that for a man if his mother had?
Absolutely, yeah, that goes for the man and women, yep, absolutely. I'm sorry, what were you trying to say?
No, I was gonna say, for male breast cancer, if the male had radiation to the chest
Mhm.
in the years before, that I believe increases the risk of male breast cancer.
For men and women, yep. Great.
I have a
Yeah.
question. When you go to your doctor once a year just for a checkup
Yeah.
and they take your blood work and all,
Mhm.
would it be feasible to have them test for tumor markers?
There are no tumor markers associated with breast cancer that are linked to either increased risk or that you have it in your blood. But that's definitely something people, when you hear about circulating tumor cells and germline cells, those are things people are definitely investigating, and they're trying to, when they talk about liquid biopsies, that's what they mean, blood tests, biomarkers. But there haven't been any for breast cancer that have proven to be actually worthy of doing on a regular basis.
So tumor markers that women are given when it's because they have metastatic breast cancer, and then the tumor markers are something that.
In some cases, yes. But as a prevention or as a screening tool, there are no markers, yeah.
For one with fibrocystic disease,
Uh-huh.
lumpy breast, you characterize suspicious lesions as lemon seed. How do you characterize those lumps?
So what is the question?
The question is,
Yes.
for one with fibrocystic
Uh-huh.
disease, the breast is generally lumpy
Yes, uh-huh,
on self-examination.
yeah.
So, how do you distinguish from, those lumps? It can be hard like lemon seed as well.
Okay, I understand. So when you're doing a self-breast
Right.
exam, how do you know it's
Right.
really, like, not just your normal
Right.
lumpy, brumpy breast versus something that's a little worrisome? I think if it's persistent, that change, the lumpiness is persistent, like you notice it over time growing or becoming harder or not changing versus shrinking, because fibrocystic disease changes a lot. And so if you don't notice any changes with it from the going down perspective, then that's definitely something to go see your doctor about. But sometimes, yes, women who have breasts that are very dense can sometimes have a difficult breast exam, and women who have fibrocystic disease, we don't really call it that anymore, but have lumpy, bumpy breasts, can also be difficult to examine. But that's a discussion, again, with the primary care, because maybe you need additional imaging besides just the mammogram. Yeah.
Thank you.
Yes?
My question may be out of place in this session about screening.
Okay.
But can you tell us something about the meaning of HER2 and ER, PR?
Oh, yes. So that's related to how cancers grow, and that's specific to individuals with patients or individuals who actually have breast cancer, and is related to how they should be treated. It's guidance in their treatment.
Now, I will ask, where I'm going, but, I was not told anything about the result, my result after biopsy.
Okay.
Can I take that to mean there's no concern about it?
No, I would definitely ask. Yeah, yeah. I think, you know, again, the things to remember, the takeaway from this is that, you know, you have to engage with your doctor in conversation, and you have to ask the why. If you had a biopsy, what did it show? It was fine. It was normal. Okay, why do you say it was normal? You know, having a little bit more of that understanding is going to propel you to seek out the right treatment, because doctors make, I'm not saying they're going to make a mistake, but they make mistakes, or you might bring to light things that they didn't know about, or you might bring to light things they didn't think about before. So having a shared discussion about screening is extremely important. Yeah.
How would you treat a woman who has two different types of cancer, like a triple negative and then HER2?
Yeah, I'm happy to discuss that with you individually.
Oh, and I don't have it, so I'm
Yeah,
just
yeah.
curious, because I've seen, on websites.
Yeah,
So, I mean, what, as a doctor, what, how do you make a
Oh, there's a
decision?
lot of things that go into the decision about how to treat breast cancers. It's extremely individual, and treatments are very different.
Yeah, but
So
if someone-
just having that information would not tell me how to treat that patient.
Oh, I see, all
Yeah.
right, yeah, because it's interesting, I never thought that you could have that.
Yeah, yeah, you can. Yeah. Okay, thank you.
Thank you.